Assalamu alaikum, Miss Shahana. My name is Ariba Javed. My roll number is BP16500039. I belong to 5th Professional Air Morning, course number PHP705, Pharmacy Practice. Today I am going to discuss rational and irrational drug uses. The drug assigned to me is Lumefantrine and Artemether. Introduction. This medication belongs to class of drug known as anti-malarial. Malaria is an infection caused by mosquito bites. Malarial parasite enters the body and live in body tissues such as red blood cells or liver. This medication is used to kill malarial parasite living inside red blood cells. This product is not used to prevent malaria. Mechanism of action. Artemether and lumefantrine exert anti-malarial action in the food vacuole of parasites. They interfere with the conversion of heme to the non-toxic hemozoin, malarial pigment. Both inhibit nucleic acid and protein synthesis. Artemether and its active metabolite dihydroartemisinin DHA are rapid schizonticides. Its antimalarial activity is attributed to their endoperoxide moiety. Lumefantrine is a dichlorobenzylidine derivative. This active mechanism of action is still unknown, but it is thought to inhibit formation of beta-hematin by complexing with hemine. Indications. Number 1. Treatment of uncomplicated Fusarium malaria. Number 2. Treatment of uncomplicated malaria due to other Plasmodium species when chloroquine cannot be used. Number 3. Complication treatment following parenteral therapy for severe malaria. Adverse effect. Blood and lymphatic system disorders like anemia, cardiac disorders like palpitation, QT prolongation, gastrointestinal disorders, abdominal pain, nausea, vomiting, diarrhea, administration site conditions, fatigue, fever, malaise, hepatobiliary disorders, hepatomegaly, metabolism and nutrition disorders, decreased appetite, mucosal, skeletal and connective tissues disorder, chills, myalgia, nervous system disorders, dizziness, headache, vertigo. Psychiatric disorders, sleep disorders, insomnia, respiratory and thoracic disorders, cough, rhinitis, skin and subcutaneous tissue disorders, pruritus, rash, potentially fatal anaphylaxis. Limitations of use. Lumefantrine and artemether are not approved for patients with severe or complicated Plasmodium falciparum malaria. Lumefantrine and artemether are not approved for prevention of malaria. Drug interactions with drug examples. Decreased plasma concentration with strong CYP3A4 inducers. Additive QT prolongation effect with antiarrhythmic class 1 and 2. Antipsychotic, antibiotic, non-sedating antihistamine, and hormonal contraceptives. So these are the conditions in which the lumefantrine and artemether cannot be given. Drug-drug interaction. Terfenadine, antiarrhythmic tricyclic antidepressant. Administration may cause increased risk of cardiac condition. Clarithromycin may significantly increase the blood levels of artemether. Drug with inhibitors of CYP3A4 increase the plasma drug concentration, and enzyme inducer reduces plasma drug concentration of artemether. Dose form, strength, route of administration. 20 mg artemether, 120 mg lumefantrine, tablet or capsule, it's an oral route. 80 mg artemether, 480 mg lumefantrine, tablet or capsule, Route of administration is oral. Dosage and administration. Dosage in pediatric patients, according to their weights, it is divided. 5 to 15 kgs administers 6 tablets over 3 days, 1 tablet initially and again after 8 hours on the first day, followed by 1 tablet BID morning and evening for the next 2 days. 15 to 25 kg administered 12 tablets over 3 days, 2 tablets initially and again after 8 hours on the first day, followed by 2 tablets BID morning and evening for the next 2 days. 25 to 35 kgs administered 18 tablets over 3 days, 3 tablets initially and again after 8 hours on the first day, followed by 3 tablets BID morning and evening for the next 2 days. Dosage in adult patients 35 kg or greater. As in adults, administer 24 tablets over 3 days, 4 tablets initially and again after 8 hours on first day, following 4 tablets BID morning and evening for the next 2 days. Administration. Administer the drug with food. If patient vomits outdoors within 1 to 2 hours, give another dose. Dose adjustment. In pregnancy and lactation, no evidence of contraindication is shown from clinical trials. In hepatic or renal impaired patient, no evidence of contraindication is showed in patients from clinical trials. Drug toxicity. There is no information on toxicity of higher doses of artemether and lumefantrine. Symptoms of overdose may include severe dizziness, fainting, slow, irregular heartbeat. Rational uses. Combination of the two medications, artemether and lumefantrine. It is used to treat malaria caused by Plasmodium falciparum that is not treatable with chloroquine. It is not typically used to prevent malaria. This combination is an effective and well tolerated malaria treatment, providing high cure rates even in areas of multi drug resistance. Irrational uses. It may lead to negative consequences, including ineffective treatment, unnecessary prescriptions of drugs, and development of resistance of drugs, adverse effect and economic burden on both patients and hospital. Alternative choice with reasons. Zither tablet 80 to 480 mg. It contains the same combination, but it is affordable and cheap according to pharmacoeconomic point of view. Zymol plus suspension 15 to 90 mg 60 ml. It contains same combination, but it is affordable and cheap according to pharmacoeconomic point of view. Artemether and lumefantrine brand names in Pakistan. The available brands in Pakistan are Artelium. Strength is Artemether 20 mg, lumefantrine 120 mg. Dosage form is tablet and it's an oral. Manufacturer W. Woodwards Pakistan Private Limited. Its price is 280 rupees. Comether. Artemether 20 mg, lumefantrine 120 mg. It's a capsule. Dosage form is oral. Manufacturer is Helix Pharma Private Limited. Its price is 320 rupees. Malaria. Artemether 80 mg, lumefantrine 480 mg. Its tablet. Dosage form is oral. Manufacturer is Barrett Hodgson Pakistan Private Limited. Its price is 341 rupees. Now the case study which I am going to discuss today is an 11-year-old boy from northern part of Thailand was administered to the hospital CMUH due to sustained fever for 10 days prior to admission. He presented with fever, chills and had no symptoms of cough, running nose or other respiratory tract symptoms. His appetite was normal. He had no jaundice, vomiting or diarrhea. The boy had no history of underlying diseases. He had no drug allergies and his vaccination history was complete. 3 days before administration to the CMUH, he developed stomachache and had several episodes of vomiting. He also complained about malaria but did not have any hemorrhage. Laboratory studies showed hemoglobin concentration of 12.2 grams per deciliter. Hematocrit is 38%. White cells count 11,810 cells per millimeter, with 70% neutrophils, 11.2% lymphocytes, 13.7% monocytes. The platelet count is 3,83,000 cells per millimeter. His peripheral blood smear showed normochromic red blood cells with several target cells and few basophilic stippling and few ring-formed trophozoites of Plasmodium falciparum in normal-size red cells. Liver function test revealed a total protein of 8.1 grams per deciliter, albumin 4.4 grams per deciliter, globulin 3.6 grams per deciliter, alkaline phosphate 229 microliters, cholesterol 118 milligrams per deciliter, aminotransferase 35 microliters, alanine transferase 32 microliters, total bilirubin 0.53 milligram per deciliter, direct bilirubin 0.09 milligram per deciliter. His blood glucose was 99 milligram per deciliter. His blood chemistry levels and urine analysis were normal. Anti-HIV was negative. His erythrocyte sedimentation rate was 22 mm per hour and C-reactive protein level was below 3.3. On admission, his physical examination revealed body weight of 30 kg, high grade fever 104 degrees Celsius, heart rate 140 BP and respiratory rate 30 breaths per minute. He looked sick and had a flushed face. His breath sound was normal, but he had tachycardia. He has mild tenderness on the upper right side of the abdomen without abdominal tenderness. His liver was mildly enlarged with firm and sharp margin without tenderness. His spleen was normal. He had drowsiness but good orientation on time, person, and place. No neurological defects were found during administration. Soap notes. Subject: chief complaint was Plasmodium falciparum malaria. Age 11 years. Gender male. Weight 30 kg. History: high grade fever 104 degree for 10 days prior to admission with fever and chills. Had no symptoms of cough, running nose or other respiratory tract symptoms. Heart rate 140 beats per minute. Respiratory rate 30 breaths per minute. He had a flushed face. 3 days before admission to the hospital, he developed stomachache and had several episodes of vomiting. Object: laboratory results. Hemoglobin concentrations 12.2 grams per deciliter. Hematocrit 38%. White cells count 11,810. Neutrophils 70%. Lymphocytes 11.2%. Monocytes 13.7%. Platelets counts 3,83,000 cells per millimeter. Blood glucose 99 mg per deciliter. Erythrocyte sedimentation rate 25 milliliters per hour. C-reactive protein level below 3.3 mg per liter. Total protein 8.1 gram per deciliter. Albumin 4.4 grams per deciliter. Globulin 6 grams per deciliter. Alkaline phosphate 229. Cholesterol 118 mg per deciliter. Aspartate aminotransferase 35. Alanine transferase 32. Total bilirubin 0.53 milligrams per deciliter. Direct bilirubin 0.09 mg per deciliter. Normochromic red blood cells with Plasmodium falciparum. Assessment: this 11-year-old boy presented with Plasmodium falciparum malaria. Malaria is a major mosquito-borne public health problem in tropical regions worldwide. This is the case reported in Thailand. In this case, we recognize this malaria for three reasons. First, the boy had received effective drugs for malaria treatment at hospital prior to moving to Thailand, but in spite of this, his fever still persisted. Last, his physical examination revealed high-grade fever, 104 degrees Celsius, with fever and chills, a flushed face, and a mild hepatomegalia. Even through malaria, patients usually have anemia. We therefore perform early investigations for malaria. The swift recognition of malaria in our case would have positively affected treatment outcomes. Our good treatment outcome could also be the result of having received earlier effective treatment for malaria, which usually had mild clinical symptoms. Plan. The patient received arterium, Artemether+Lumefantrine combination tablet, an anti-malaria medication intravenously due to poor oral intake for 4 days. The arterium was switched to an oral form on the 5th day and was continued for 1 week. He also received mefloquine on the 2nd day of administration and primacunine to kill gametocytes before he was discharged from hospital. Owing to poor oral intake, he received a normal saline infusion of hydration for 7 days. He was monitored every day for hemoconcentration and thrombocytopenia. After the initiation of anti-malaria treatment, the patient's clinical outcome improved. His appetite returned to normal in 1 week. There was no complication for malaria infection such as cerebral malaria, hyperphagia, severe anemia, hypoglycemia, metabolic acidosis, and seizure in the boy. His peripheral blood smear 12 hours after starting the treatment did not contain in any ring form trophozoites anymore. However, he still had low-grade fever for 6 days after administration. We assume that this persistent fever could be the result of the febrile stage of malaria and was longer than usual due to co-infection with malaria. He was also monitored daily for heme concentration and thrombocytopenia. His fever gradually resolved at the end of the first week of admission. He had no sign and symptoms of fluid leakage and shock, although his lowest platelet count concentration was 68,000 cells per millimeter. On the 6th day of admission, he had only minor and no serious bleeding complication occurred. His clinical outcome returned to normal in stages. This boy was discharged after admission to the hospital for 8 days. References. I used Wikipedia. I use WebMed. I use Medscape. I use Drug Information. I use Medical Store website, and I also use NCBI articles to do my presentations. These are my references which I used to prepare my presentation. Thank you.